What we're looking at is something called a uterine window, which is the incomplete separation of a uterine scar from a past C-section. Usually, uterine windows are found incidentally during a scheduled C-section. This is a difference from what's called a uterine rupture, which is the complete separation of a uterine scar. And that can be a potentially catastrophic complication for mom and for baby. So our biggest concern is a window potentially progressing into a rupture. So what our study found was that an increasing number of C-sections with a pretty significant risk factor for these uterine windows. So if a patient has 3 prior C-sections, there's a 15% chance of finding a window at time of delivery, even if they haven't labored and even if they didn't have a history of a prior uterine window or rupture in that situation. This is a big jump from the 9% if they have 2 prior C-sections and the 3% if they just had 1 prior. The biggest concern we have regarding the window is the window becoming a rupture, and we're especially concerned about that happening in the setting of labor. Labor becomes much more common the further pregnancy progresses, so we think that for patients with these higher order C-sections, or if patients have 3 or more prior C-sections, they may benefit from a slightly earlier delivery sooner than 39 weeks. So the ACOG recommendation for delivery of elective repeat cesareans is 39 weeks, but unfortunately, it doesn't leave much room for adjustment based on something such as a number of prior cesareans. We do think that uterine windows are something to be taken very seriously, so we do think that the ACOG's recommendation should be adjusted a little bit to allow for more individualized recommendations for delivery. I think patients and clinicians should understand that, again, with these higher order cesareans, they are an increased risk for a uterine window. And with the window, it's something that we wouldn't want them to go into labor for, again, for that potential risk to progression into a rupture. We would counsel them that in this situation, it may be prudent to consider delivery sooner than 39 weeks, but that ultimately delivery recommendations has to take into consideration a lot of other things, such as the potential impact on the neonate for an early term delivery, as well as other perinatal outcomes, especially ones regarding severe morbidity that should also be considered when we're making recommendations for delivery timing. So for patients with a known history of a uterine rupture, we manage them according to ACOG recommendations, which is a scheduled repeat cesarean delivery between 36 to 37 weeks. When it comes to a history of a uterine window, there are currently no formalized recommendations as to how they're managed or delivered. In our practice, we routinely recommend that these patients be delivered via a repeat scheduled C-section anywhere between 36 and 38 weeks. I think community providers can definitely take into consideration the increased risk of uterine windows with their higher order C-section. So I think it's really worthwhile if they counsel their patients to be very cognizant of symptoms concerning for labor, for instance, as well as the signs or symptoms of something more concerning like a uterine rupture.